Hello, I'm Jan Leifman.
And I'm Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Alok Khorana. Dr. Khorana is the Sondra and Stephen Harris Endowed Chair in Oncology Research, the Vice Chair at the Taussig Cancer Institute, and the Director of the GI Malignancies Program at the Cleveland Clinic Lerner School of Medicine of Case Western Reserve University.
In today's presentation, Dr. Khorana discusses the latest updates in the therapeutic interventions for colorectal cancers.
Did you know that Dr. Khorana is also the author of the Khorana Risk Score for venous thromboembolism in cancer patients?
A true inspiration in the field of oncology.
So let's tune in and learn from this global leader.
So a lot of exciting stuff is coming out about the role of the microbiome in young onset colorectal cancer and in colorectal cancer in general. And I hope you'll follow this exciting literature as it evolves. Let me turn my last few slides to sort of what can we do now in terms of practical applications and solutions for young onset colorectal cancer patients. I think the number one thing any healthcare provider can do, should do, must do is prevention. And we've known that colonoscopy is associated with finding cancers early, finding polyps and removing polyps that will never become cancer. Yet colorectal cancer screening has sort of plateaued off in the 60-70% range for most populations. We've known about this for 2 decades now, and we can't seem to sort of move that ball further. And so it's really incumbent on healthcare providers to make sure that there's appropriate screening. Screening for all people should start at age 50. But for high-risk individuals, that's anybody with a family history of colorectal cancer or a family history of polyps, or people with known hereditary syndromes, or people with known inflammatory bowel disease, screenings are different for those patients. For family history of cancer or polyps, you should start at least at age 40, and ideally 10 years younger than the youngest person in the family to get cancer or polyps. So if you have I have patients who are in their 40s who develop colorectal cancer, then their children should start in the 30s. I think lifestyle modification, the type of diet and lifestyle that I've described, more exercise, less red meat, less processed meat, more aerobic exercise, all of that is good for general cancer prevention. It's good for cardiovascular disease prevention. And so these are things that we should be encouraging our patients to do. And then finally, and I can't stress this enough, symptom recognition is really important. I can't tell you how many patients have symptoms of GI distress, abdominal pain, occasional blood in the stool, and all of it is either ignored by the patient or ignored by the provider because the expectation is, oh, you're young, you can't have cancer, therefore it must be, hemorrhoids or something else. And so it's important that symptom recognition and early diagnosis occur in cancer patients. As we've seen already, that this delay in diagnosis, the average number of doctors that a young patient sees is much greater than an average number of doctors that an older patient sees to get to a diagnosis. So this really needs to be corrected. This is actually a survey from the Colorectal Cancer Alliance, asking patients how long did you experience symptoms before going to the doctor. And more than 75% of patients said they at least saw 2 different doctors. And almost 20% or more, actually almost 40% said they saw either 3 or 4 doctors or more before they were diagnosed. So again, very important that we make sure that we capture this. Recent guidelines from all of these different societies have changed. So American College of Gastroenterology, ACS, US Preventive Service Task Force, all of them are now recommending that colorectal cancer screening start at age 45, not at age 50. So that's a big change in terms of public health recommendations. And again, a reminder that that's for people with average risk, not for people that have a family history or of polyps or cancer or have IBD. And those patients start even earlier, depending on the exact type of risk. Another issue that our younger patients deal with is that at the time that they're diagnosed, which can be in their late 20s, early 30s, late 30s, many of them are still creating families or may not even have started a family. And so it's important to refer these people to a reproductive endocrinologist to make sure that their fertility needs in the future are addressed. We need to emphasize sort of the risks of sexual dysfunction, because many of these surgeries require pelvic interventions, which may lead to dysfunction later on. This is a very different population. They're employed full time. They may not have as much in savings as older patients do. They may not have as much insurance coverage as older patients do, may have a greater need for mental health and need help for depression. And all of these things need to be better addressed in the younger population. Kathy Yang recently put together this sort of graph of looking at sort of the whole aspect of treating colorectal cancer in younger patients, with a special emphasis on genetic counseling, financial guidance, fertility preservation, recognizing that they're still achieving their academic, professional, and career ambitions, emphasizing their mental and social well-being, and addressing sort of long-term survivorship in a different way than we would in older patients. And so that's important to keep in mind as well. And many of these solutions for young onset colorectal cancer can actually be deployed now. Education and awareness of both patient and physician, that's something we're doing tonight, and we should continue to do, spread it through our networks. Genetic testing, very important for all family members with colorectal cancer. So if you know of someone who has a family history of colorectal cancer, important to discuss both screening and potentially genetic testing. Screening guidelines have changed down to age 45, so let's remember that. We can deploy other solutions, whole genome sequencing for everybody, for instance, but there are barriers to doing that, particularly cost. Colonoscopy, as I mentioned, has reached a plateau, and so that needs to be considered. Risk-adapted screenings, and then streamlining and coordinating care and communication across sort of the different barriers to access is also important. And those barriers to access are actually very different in the younger population than they are in the older population. And so we need to take that into account as well. At the Cleveland Clinic, we've actually created a center for young onset colorectal cancer led by one of our colorectal surgeons, David Liska. And the goal here is to optimize outcomes for young patients with colorectal cancer, where we do a very coordinated multidisciplinary care, research, and education of those patients. We provide a clinical coordinator, genetic counseling, fertility preservation tactics, expand a surgical approach since younger patients are more likely to undergo surgery safely, provide psychosocial support, survivorship, integrative medicine, and we follow these patients prospectively to better learn from them, and I've shared some of the data that we've generated through research from this population as well. So hopefully I've introduced you to sort of this new mysteriously rising illness of young onset colorectal cancer, and you've learned something new this evening. To summarize, it's rising at alarming rates in the United States and many countries worldwide. The factors underlying this rise are not fully understood. It may include obesity, diet, lifestyle, and may influence the gut microbiome and other aspects of the microbiome to lead to cancer. Our group has helped identify several clinical risk factors and geospatial regional differences, as I just showed you. In the United States, at least, Black and Hispanic patients are at greater risk, but the majority of young onset disease does still occur in white people. Hot and cold spots have been identified, specifically for young onset disease. Those hot spots are in the northern regions around the Great Lakes and Appalachia. And tumor microbiome analyses have identified microbial signatures associated with young onset disease with a particular role for Akkermansia. Lots of unanswered questions still remain. We still don't fully understand the exposome, the different environmental exposures that people experiences. Which of those specific elements are driving young onset disease? Is it exposure to antibiotics at a young age? Is it something prenatal or natal? We don't fully understand that. We don't understand genetic epigenetic signatures associated with this exposomal elements. We don't understand the specific periods of development that place the colon at risk for cancer. We've often linked obesity to cancer and to colorectal cancer, but how does that link actually happen? We don't understand that. Is it inflammation? Is there something about obesity? Is it about glucose control? We don't really understand any of those aspects. The role of the microbiome, they're beginning to understand, but we're not quite there yet. And most importantly, what interventions, especially diet and lifestyle, resource neutral or resource poor interventions, can mitigate this rise? These are really important questions, and I hope you'll join me in taking part in this field as it evolves over the next few years.